This video will discuss an Edentulous double arch chrome surgery with Dr. Rita Kutsakovich in Beechwood, Ohio, longtime customer of our laboratory, and really did a beautiful job with this case. So double Edentulous is a little unique situation because the initial pinning is with both pin guides in the mouth. And because Dr. Made new dentures for this surgery, she and we carefully set the teeth exactly to the right position for the patient so that the teeth in the pin guides and the teeth in the workup denture will be the same as the prosthetic that the patient's going to wear home. And that was key to how we pinned this particular case. And we'll talk about that as we go through the case. Let's just talk a little bit about day of surgery. This is the universal surgery guide. This is the long drill kit from Simplant. If you're going to use this kit, which is, we recommend it, it's a wonderful kit, but also purchase the guided driver for the implant that you're going to be seating, because this is just for drilling the holes. But you need a mount. You need a guided mount from this company to drive the implant. In this case, we used a freehand mount from Nobel. Worked just fine. It had indexing on it, so we got the rotation right. But you really want to, guide your implants. But we worked through it. It was okay. These are IDS's, the Megagen IDS Reflect Line implants. These are Nobel active clone implants. Just to give a little bit of background information, because you'll be watching several slides. Might be curious what systems we're using. I laid everything out on the surgery mat. Getting ready for surgery. This is going to be a C2F small hole extraoral conversion surgery performed by Ro. And let's get into it. On the left is the scan appliance, the dual scan in occlusion in the patient's mouth. And on the right is our setup that we completed based on the scan appliance. So the idea here is that the teeth were set when fabricating a denture into the ideal position. We copied those teeth in our digital setup so that when you're pinning, you can pin the upper with the lower pin guide, and then once you convert to the prosthetic, the lower pin guide will fit against that upper converted prosthetic. And we'll show you what we mean by that as we work through this video. That's very user-friendly way to complete a double Edentulous case. On this case, this was our inaugural launch of the windows in the Edentulous pin guides, so that when you seat them individually, you can make sure that they are seated fully. You can see the palate, you can see the ridge, they're down. This was holding up a little bit in the vestibule with the chrome locks, but once that was anesthetized and relieved, it fully seated down on the tissue, or on the ridge. So you can see that the lower and the upper integrate. On the upper, we put an integrated bite so that you know that the lower and upper dentures are coming together as planned, not as the condyle is going to work on that day of surgery. Right? So both dentures are seated. Teeth go into the bite. You have a positive seat. Watch for any tipping or rocking of either one of the pin guides when you're seating. But if they're both seated and the bite goes in without rock, then you know that you are fully seated and ready to go, which was the case in this surgery. It worked out perfectly. Just an image of the windows. And so now what will happen is both pin guides are seated at the same time. Now this was originally for try-in, just to make sure everything was seated properly. And then the metal will be added. So let's just watch how this is performed. The upper is in, the lower is in, just like with a denture would practice, to make sure there's no tipping. All right, so we know the upper is fully seated. We know the lower can be fully seated with some tissue holding it up, but a little bit of pressure, and it's sat. And so the doctor is just opening and closing and making sure that there's no rocking and the bite is closed. And I know I sound like I'm repeating here a little bit, but it's so critical to make sure these pin guides are seated fully.
Open, put your tongue up, slide it back,
fixation
and close.
base, the implants, the teeth, everything is in the right position as we work through the surgery. It's key.
She's lying back.
So as always, patient is in a little different
slide
light.
it forward a little bit.
Lying down or standing up, or how far you are into the surgery, or numbness, etc. Patients, especially edentulous patients, they just change their
They're
lights.
seated, I can feel they're seated, and I kind of got her into the.
So she can
Nothing is
hear, she's saying,
moving,
I
but I
can
got
feel
her
it seated,
into
I know
this.
it's fully seated.
So that's good. So let's take them both out.
Okay.
Put the upper fixation base in.
Okay, open.
All right, good. So then the next step is to remove both pin guides and make a crestal incision on the maxillary. These cases almost always start on the maxillary. So crestal forward, no lingual crestal, no lingual. There's no reflection on the lingual at all, because this is the tissue that will support the pin guide. And you lay the buccal flap, labial flap, so that the pins can go directly into bone and not through tissue. That's the way we found the best way to pin these, as opposed to pinning directly through the tissue, then taking the pins out and laying a reflection. That often causes irritable tears in the tissue. It also means you have to find the holes again. This lingual tissue is thick enough, this keratinized tissue is thick enough to support the pin guide. So we think that's the best method to do so. Make the incision back to the back part of the pin guide. The most important part of the incision is that it extends back to the fixation base, because you want to have the tissue reflected above the fixation base, so it's not getting tucked underneath it and it's not in the way. So with full reflection, go back to placing both pin guides in. Right, you make sure that the tissue is above the metal. You can use any kind of spatula tool to make sure the tissue is up there. And then, of course, the most critical part of all is making sure that the pin guide does not move during drilling. So on these surgeries, we always say, always, to drill on the maxillary. You're going to stop 3-4 millimeters short of full depth, right about there.
Okay, good.
Okay, and let me just hit pause here on the video. You can't really see very well, but the assistant's hands are holding the chin and the mandible to the head. Both pin guides are in. It's just imagine a patient's wearing both dentures, and you're holding the head together, the jaw and the head together, and you're using quite a bit of force. Now, you don't want to, of course, overdo it and tip or squeeze the tissue too much. But remember that the patient is now anesthetized and the tissue is a little bit swollen. So we waited about 5 minutes or so after injections to make sure the tissue could swell, the swelling could go down, and we could use the pin guide to kind of dissipate that swelling. Just kind of manipulate the tissue until the denture, you can feel a full seat again. So with both seated, assistant holds the chin down during the entire pinning process of the maxillary. Very, very, very important. So drill down to about 3 or 4 millimeters short, place a pin. Do not move to the next site until you have a pin in here.
Good.
And do not tap this pin in. If you tap the pin in, you run the chance of pushing the metal, the pin guide, and everything towards the bone, towards the patient. So we are not ready to use a tap yet. Go to the next site, follow the same protocol. 1, 2, 3, 4. Put all 4 pins in. They're holding the pin guide now in 4 different trajectories. The assistant holds onto the chin the entire time, and then at that point, use a surgical mallet and tap these pins in. And if the patient is under local, talk to the patient, because usually this is it's always an odd sensation when somebody's hammering on your head. So use the back of a mirror, use the handle of a mirror, unscrew the mirror head off, put the mirror rod on top of the pin, and then use the hammer outside the mouth and tap. Tap all 4 pins until they're down to metal, and you will hear a different sound when the pin hits the metal. So you'll hear a tink, 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 thud, and you'll know that you're at metal. Don't tap anymore. You're metal to metal, and that is the goal. Okay, that's the pinning process. So once all the pins are down, you can see they're flush here. The pin guide comes off. You will make a lingual flap now and raise the lingual flap down to the level of the bone reduction. Okay, so a little bit of flap was laid, and I think Doctor ended up flapping a little bit more. Most of the time, a doctor, there isn't much bone reduction here, but most of the time a doctor will tie a stitch here to hold the tissue back. And reduce the bone down to the level of the metal. And this is a matter of feeling it with your fingers or visually seeing that the metal and the bone are at the exact same height. Take time here to make sure that it is. You can ask your assistant. They have a little different vantage point from the other side of the chair, and just talk about it. Talk your way through it until the bone is reduced. We definitely use a very aggressive burr. Either we have a burr we sell called Mr. Hungry. It's a Comet burr, but we call it Mr. Hungry because it's very aggressive and very quick. But there's other burrs that we recommend as well. Once you have enough bone reduction, enough bone reduced, try in the carrier guide. This should seat passively. If it's rocking, it's either bone or tissue. Right here it was bone, little tissue in the back. Remove the tissue out of the way, and then just keep adjusting until this seats. Once it seats, you can remove it. And then in goes the osteotomy guide, and then just start drilling the sites. Go through that the whole process. You can see the key here, the spoon, and then and the drill. So I won't go through the whole drilling process. Next step is to drive in the implants, and again, you want a guided mount. And then again, this worked out fine, but you want a guided mount. This should fit right into the sleeve intimately. And then use your indexing here to control the rotation, because on Chrome we put nubs, call them nubs, lack of a better word, but they're indexing nubs. And so one of these dots will line up with one of these nubs, and then you know you have the indexing, the implant in the right rotation. All right, so you turn this either clockwise or counterclockwise until these line up. All right, implants are in, the carrier guide is seated, the multi-unit abutments are in. And in this case, I'll flash forward a little bit here just to show you. We picked up these temp cylinders. So I'm kind of flash forwarding pretty far, but the draw on this case was planned. It's proper. It's correct. But the draw on this, we angled this temp cylinder distally so that we could get a little bit more of an AP spread on this arch. So that means that the draw is not possible, that these 2 and these 4 we're not going to have on the same path of insertion as planned. So doctor picked up the anterior 2, took them out of the mouth, right? They've already been picked up, and then added 2 temp cylinders into the posterior, and then left them loose. Just they have a little bit of wiggle to them. And then we manipulated the prosthetic, kind of wiggled it over those 2, then tightened them down, and then picked them up. It actually worked out really well. And when you do pick these posterior, any in this situation ever, you always want to screw down the prosthetic back down to the original 2 that were picked up, or 3 or 4 picked up, because that way you know you have a repeated positive seat. Right? I showed this because we drifted a little bit anteriorly, and we actually had a little bit of a digitally we removed a little bit of an arc to make a little bit of space for that abutment. Kind of a unique thing that we do. We've kind of learned that as the years go by, that if it's too close to the metal, then notch out the metal. So the prosthetic, the rapid appliance was picked up, and it was brought back into the laboratory, and we completed the conversion. And I won't go through the whole conversion process. I'll go through a little bit of it, not much. But essentially, we fabricate a model with C2F where we attached analogs and MUA heads to the prosthetic. We put it in our model. We backfilled the holes to make a model. All right, model's been made. And then we inject from the lingual to pick up the copings. And we have videos on the whole C2F process, which I'd recommend to really to anybody to pick up. It's a little more tricky than just filling holes and cutting down metal, but the result is so much better. This is what it looks like, just small holes. Right? So this is what it would have been if we would have picked this up in the mouth. We would have had to clean all this up, create teeth, right, for seating, and the patient would have to wear this for 6 months. That's just sometimes the way it goes. But if you're using C2F small hole or no hole with Smile Lock, then you'll either have no holes or you'll have really small ones, and then the occlusion is preserved. That's why we love this C2F process. And this will be cleaned up a little bit more. Just wanted to show you what it looks like after injecting. So the tissue is covering the MUAs a little bit. So doctor used a burr and cut it up. This will heal very nicely. Another stitch went in here, and the prosthetic was seated. And so let's step back a little bit here. So now the upper has been converted, picked up. The upper is finished. Now normally with a dentate case, you'd move on to the lower without seating the upper prosthetic because you don't need the prosthesis in the upper to work on the lower. But in a double edentulous, the lower pin guide is going to fit into the upper teeth, as in a bite, a regular bite. So that means we are going to seat the lower with the metal, tissues reflected, and we practiced a little bit before taking this picture. We didn't make any adjustments, but the pin guide seated fit right into these teeth. It was a perfect bite. All right, we can judge this a little bit, how the midline was off a little bit. There was something a little bit rotated, and we'll have to watch out for that when we're in surgery. But the bite, the vertical, the position, everything was down. So now we just follow the same process. The assistant is holding the chin and the head,
All the way?
the jaw and the head together carefully, lots of pressure. And doctor follows the same protocol of drilling 1, 2, 3, 4. Now, on the lower,
Pin number 2.
you could stop 1 millimeter short.
Okay.
You could even drill to full depth in some really hard bone. You don't have to leave as much of the pin exposed for tapping in. It's just not as necessary. We do recommend using a tap, using a surgical mallet on every case though. So leaving it 1 millimeter up is still good. But our step-down drills go into the cortical bone, and the step-down tip is a little bit narrower than the tip of our pins. So theoretically, if you're in really hard bone, you should still have to do some tapping, even if you drill full depth. So I'm going to fast forward here, drill, pin, and then tap. And you can see here's the mirror. That's the mirror separated from the handle. And see if we can hear the noise difference.
Okay. Very good.
When you're in surgery, you'll hear the noise. It's a distinct noise when the metal is
Okay, now
Yep. Now open and
open and take it.
take the pin guide out, undo the blue things, and off we go.
So now we need to reduce that.
So pin guide comes out, and then bone reduction is completed.
We do.
Bone reduction is completed until it's completely reduced down to the metal. Try in the carrier guide, and then we are just we're in repeat mode at this point. All right, so implants go in. We used our contra angle driver in this case, which is really handy to use. I'd recommend absolutely having a contra angle instead of 3 or 4 or 5 fingers back in the mouth holding onto a screwdriver at a 30-degree angle, pointing distally in the mouth. Get a contra angle. And then, abutments are torqued in. The carrier guide is placed Temp cylinders are on, gaskets are down. All right, plugs are placed. Prosthetic is picked up, taken back in the lab. We went through the C2F process and made a beautiful prosthetic. Repeat, repeat, repeat. For the most part, that's CHROME. It's a very systematic approach. It's just sometimes with double edentulous or even single edentulous, the protocol is different for pinning, and it's just key to follow those the simple steps, but just follow those steps and it'll work out really nicely. All right, nice suturing. Case is delivered. Do a little flashback of this patient. She was a severe perio patient 6 months ago. Completed immediate dentures and then made the new dentures and went into surgery, and just a lovely result. Let's play a little video here of this.
Oh wow.
The case. Now remember, both pin guides are sitting on tissue. All right, so we know that this case was right from the get-go, from the start, because of those dentures that were fabricated. So continue to watch just to the end here, because you'll see that without touching the occlusion,
And bite and hold.
the equilibration paper just leaves some lovely marks.
Open.
Yeah,
Oh my.
No touch.
really couldn't be any better.
Yeah, I don't think I need to touch anything.
Doctor's not going to do anything. Have the patient back in a couple days just to double check the bite again, see everything, and that's it. Double edentulous surgery. Thank you for watching. We are always here to support. We even have a live concierge service. If you're in the middle of surgery and have issues, questions, give us a call and we can do a FaceTime. Thank you.